milligrams per day, but the weight loss achieved is more or less similar with all three drugs. This is the change in baseline that is seen with empagliflozin in different categories of patients. This is the pooled group where all these patients have been looked into together, the monotherapy group, the metformin group, and so on and so forth. It is obvious that when it is used either as a monotherapy or in combination with metformin, it is likely to achieve much better results for weight loss. But when you combine it with sulfonylurea or insulin or pioglitazone, the weight loss benefit might be slightly reduced because of the weight gain seen with these other drugs. But the weight loss that has been, this is for the HbA1c. This is the chart for HbA1c. The chart for weight loss will be coming up in the next slide. So when you combine them, this drug with metformin, you would achieve an HbA1c reduction of 1.5 to 2%. Again, it depends upon the patient's baseline HbA1c. So higher the baseline HbA1c, greater would be the reduction achieved with the therapy. And also depends upon the stage of diabetes for a patient. If the patient is chronic diabetic, more than 15-20 years of duration, still the drug continues to act because it is insulin. It acts in an insulin independent mechanism. But in such cases, many times insulin is simultaneously required. And when combined with, when used alone, the HbA1c reduction that has been seen is about 0.6 to 0.8%, which is more or less similar to that seen with DPP-4 inhibitors. But again, as I said, it depends a lot upon the patient's baseline HbA1c. That brings us to the second slide, which is in relation to the patient's weight loss that is seen with this drug. Compared to placebo, the weight loss is to the tune of 1.8 to 2 kgs in general. Greater weight loss is seen when you combine it with metformin or with a GLP-1 analog. As compared to that, when you combine it with insulin or pioglitazone, you might not achieve that much weight loss, but still significant weight loss can be seen. One benefit of combining it with pioglitazone in patients where pioglitazone is chosen is that it will offset the weight gain which can be caused by pioglitazone, and the patient will not be affected by the excess pedal edema and the weight gain that is seen with pioglitazone. That's about the weight loss part. Now, although the quoted figures are between 1.5 to 2.5 kgs, all of us have seen results where the weight loss can be much higher than that. Many of our patients have lost 4 to 8 kgs or even more than that with chronic therapy with SGLT2 inhibitors. So, although there is a limit to the amount of weight loss that can be achieved, still the same theory applies that was seen with HbA1c. If the patient's baseline weight is greater, you would be able to achieve greater weight loss with any weight loss therapy. This is the change in systolic blood pressure. Again, like DPP-4 inhibitors, SGLT2 inhibitors, and empagliflozin over here would cause reduction in systolic blood pressure, whether used alone or in combination with other drugs. This would be to the tune of 3 to 4 millimeters of mercury. The difference between the SGLT2 inhibitors and DPP-4 inhibitors is that despite the reduction in systolic blood pressure or even the slight reduction in diastolic blood pressure, which is seen with these drugs, there is no concomitant reflex tachycardia. So the heart rate remains normal without causing any, despite causing a reduction in systolic and diastolic blood pressure. And this is the 24-hour change in systolic blood pressure that is seen with 10-25 milligrams of empagliflozin. And when you compare it with placebo, the reduction is to the tune of 3 to 4 mm of Hg without any reflex increase in pulse rate as discussed earlier. So over a period of time, the blood pressure falls. In the initial few hours after taking the drug, the reduction in blood pressure is slightly greater than towards the end of its duration of action, or towards the end of its efficacy period. So this is the 12-week ABPM study, which was done with empagliflozin in patients with type 2 diabetes mellitus. And again, it looked at the hourly mean diastolic blood pressure at week 12. There was a difference of about 2 to 3 millimeters of mercury when compared with placebo over a period of 12 weeks. And again, this was not associated with a concomitant increase in heart rate. The dyslipidemia profile also changes towards the better when you use a drug like SGLT2 inhibitor. Although the LDL and the HDL cholesterol both increase, you would observe that the LDL cholesterol has also increased, and so has the HDL cholesterol. But the ratio remains more or less similar. In fact, it is slightly better that the LDL-HDL ratio goes down a little bit, and that would be beneficial for the patient. But it is more or less a neutral drug as far as the lipid profile of the patient is concerned. the triglyceride levels reduced. This could be due to the reduction in blood sugar levels, because glycemia is directly correlated with the patient's triglyceride level. So lower the blood glucose levels, lower will be the patient's triglyceride levels also. So, and the weight loss that is seen with this drug would also help improve the lipid profile of the patient. So this is a conglomerated table which shows the effect of SGLT2 inhibitors on glycemic control, on body weight and systolic blood pressure, either as monotherapy or as an add-on to metformin or sulfonylureas, uh, whether combined to pioglitazone. And this is in general for all SGLT2 inhibitors. And you would observe from this table over here, this row column over here, that whether used as a monotherapy or in combination with other drugs, you would achieve significant HbA1c reduction, which could be anywhere from the tune from zero point 0.5 to 0.8, 0.9%. Some of the studies have found a greater HbA1c reduction, but this is a realistic reduction that you would see with when you are using this drug. The fasting blood sugar levels also fall by about 20 to 40 milligrams per deciliter, and the post meal blood sugars fall by about 40 to 60 milligrams per deciliter, and the systolic blood pressure falls by about 4 millimeters of mercury when whether used alone or when in combination with other drugs. This is the side effect profile of the agent. We know that SGLT2 inhibitors require a specific amount of a specific type of genital hygiene to be maintained on the part of the patient, because the only side effect or the only complication that might arise from the use of this drug is the increased risk of urinary tract infections and genital mycotic infections, which have been found to the tune of about 10%. In general, the urinary tract infections were to the tune of 10% in the study. The infections were greater in the female patients as compared to the male patients. However, again, it was more or less similar to placebo, the UTI risk. When you look at the genital mycotic infection risk, this is the genital infection risk, it is greater, obviously, in the treatment arm as compared to the placebo arm. There is about 5% risk of developing a genital mycotic infection when you are using this drug. However, again, as discussed earlier, if the patient maintains necessary amount of genital hygiene and takes adequate amount of fluid, we can avoid these problems. The risk of pyelonephritis is also similar to that seen with placebo. So if the urinary tract infection is ongoing, and if we consider starting the drug at that time, that could be obviously a problem. So you have to ask the patient about lower urinary tract symptoms. A patient with benign prostatic enlargement or a prostate CA or significant post-void residue, or a patient who has autonomic neuropathy affecting the patient's urinary bladder and causing urinary stasis. In those cases, you have to be more careful about using these agents, because they can cause an increased risk of urinary tract infections and genital mycotic infections. Volume depletion, again, if the diabetic patient who is being prescribed this drug has been chosen properly, then this risk is negligible. A patient who is not taking orally, a patient who is bedridden, who is in altered sensorium or has psychological issues, who does not take sufficient amount of oral fluids, in those cases, we should refrain from starting this group of drugs. And that is a problem which is commonly seen because of the over enthusiastic use of SGLT2 inhibitors. Many times they are started in the ICU also, immediately after a cardiac procedure, even when the patient is still on hemodynamic support or the patient's oral intake is still not that good. So despite the strong cardiac protection that is seen with these drugs, it is necessary that we should ensure that the patient's oral intake and the hydration status is good enough before starting these agents, despite the numerous benefits that are seen with the drug. Confirmed hypoglycemia, because of the insulin independent mechanism, you would not expect any excess hypoglycemia with this agent when either used alone or when in combination with metformin. Obviously, when you use it with sulfonylureas or insulin, you can expect increased risk of hypoglycemia, primarily because of the other drug. This is the landmark CVOT EMPA-REG outcome, which was done with empagliflozin in patients with established cardiovascular disease. The inclusion criteria was for this study was that almost all of the patients had established cardiovascular disease. So this was principally a secondary prevention study, and we all know the results of this study. This is the only SGLT2 inhibitor amongst the 4 or 5 different SGLT2 inhibitors available right now, which has not only shown a reduction in the 3-point MACE, but has also shown reduction in CV death and all-cause death. the reduction has been to the tune of 35 to 40%, and the 3-point MACE has reduced by about 15%. The important part over here is that all of these reductions have shown statistical significance as far as the superiority over placebo is concerned. And the hospitalization for heart failure is also reduced when you are using empagliflozin, or for that matter, any other SGLT2 inhibitor. So all of these are statistically significant results, and the drug has been shown to be superior to placebo, not just non-inferior, but actually superior to placebo in achieving these cardiac benefits. These are the renal outcomes. Again, it has also revolutionized the management of diabetic patients with incident nephropathy, or patients who have developed macro or microalbuminuria. Till now, we only had, the answer to a patient's question, that how is he supposed to improve his renal health, or how is he supposed to reduce the macroalbuminuria or microalbuminuria, was that you control the blood pressure, you control the diabetes. Now we have agents like SGLT2 inhibitors and GLP-1 analogs, which definitely help in reducing macroalbuminuria, progression to macroalbuminuria, and prevent development of incident or worsening nephropathy. And the composite renal outcome, which includes end-stage renal disease, dialysis, or renal death, that has also been reduced when you use empagliflozin as compared to placebo. And the hazard ratio of 0.5 to 0.6 suggests that the improvement is to the tune of 40 to 45%. So in patients with type 2 diabetes and high CV risk, empagliflozin given in addition to standard of care would reduce heart failure, hospitalization, or CV death, with a consistent benefit observed in both those with and without heart failure at baseline. So any patient with established cardiovascular disease, or even I would say patients with high CV risk, even if they are not having history of heart failure, in those cases also empagliflozin would continue to provide excellent cardiac care, a cardiac benefit to the patient. So how early should you start? How early does the treatment initiation, how early after treatment initiation do these benefits appear when you give a drug like empagliflozin? This is a post hoc analysis of EMPA-REG outcome. And these are the results that were found. And these results have actually, confused almost all experts. And this is one of the reasons why the exact mechanism by which SGLT2 inhibitors reduce cardiac, improve cardiac benefit has not been deciphered for as of now. As early as day 17 after initiating therapy, the hazard ratio hazard ratio decreases and it reaches statistical significance. So the earliest effect has been found as early as day 17 when you for hospitalization for heart failure, when you use a drug like empagliflozin. And when you look at the composite of hospitalization for heart failure and CV death, that benefit has reached statistical significance at day 27. So the p-value at day 27 for the placebo arm versus the treatment arm, as far as these two MACE events were concerned, was 0.0445. So it reached statistical significance quite early after initiating therapy. And when you look at just CV death, only CV death, that benefit was also achieved as early as day 59. So quite early after starting this therapy, you should expect benefit in your cardiac patients. So CV trials are being conducted for almost all drugs now, which are being introduced into the market for treatment of diabetes, anywhere from DPP4 inhibitors to SGLT2 inhibitors to GLP-1 analogs. We have heard about most of these trials, the SUSTAIN for semaglutide, the LEADER trial for liraglutide, the ELIXA for lixisenatide, and so on and so forth. So we have so many trials now for establishing the cardiovascular safety of most of these drugs. And because of these trials, we have been able to find out that some of these category of drugs actually provide cardiovascular benefit also. So SGLT2 inhibitors have profile of the patient. And most of this causes glucosuria, so there is a reduction in blood glucose levels. It helps with the renal profile of the patient, reduces albuminuria, reduces the uric acid, reduces oxidative stress, reduces blood pressure also, and visceral adiposity. So because of the weight loss and the glucosuria, it affects multiple metabolic pathways and thereby helps in improving the cardiac health and the CV risk of the patient. This is the comparison of the three primary agents, the empagliflozin, canagliflozin, and dapagliflozin. We now have results with ertugliflozin also. But if you look at these results of the three trials, empagliflozin scores above all others, because not only does it help in the kidney outcome and the hospitalization for heart failure, it was the only drug which also reduced CV death. So empagliflozin and canagliflozin, both of them achieved reduction in MACE events. Declared-IMI, that is dapagliflozin, did not achieve reduction in MACE events. It did help with the heart failure part and the renal outcome part, but there was no significant reduction, statistically significant reduction in MACE outcomes, which as compared to placebo. With Canvas and EMPA-REG, there was significant reduction in MACE outcomes, which was statistically significant, but Canvas program did not show individual benefit in CV death with canagliflozin. With ertugliflozin, there was reduction in heart failures, but there was no other significant benefit seen comparable to the other SGLT2 inhibitors. So that has altered our guidelines. We now know that although metformin has been considered as a first-line drug for a very long time, and as of now also, arguably it is still the first-line drug for treatment of diabetic patients world over. But now it faces competition from SGLT2 inhibitors because of the obvious benefits seen with SGLT2 inhibitors as far as the weight loss is concerned, the cardiac benefit is concerned, and the renal benefit. So guidelines have been altered to an extent. The European Society of Cardiology actually recommends that you start with SGLT2 inhibitors or GLP-1 analogs in patients with established atherosclerotic cardiovascular disease or patients with heart failure before even starting metformin. And this is primarily for drug-naive patients with irrespective of their HbA1c levels. So it is not necessary that the patient's HbA1c should be more than 7, 7.5, or 8. If you are initiating SGLT inhibitors, you can start them even at 6 or 6.5 in a treatment-naive patient if the patient is having established cardiovascular disease. Of the level of HbA1c based on the patient's cardiac or renal profile, you can consider starting SGLT inhibitors even before starting metformin based on the ESC guidelines. The ACC AHA guidelines and even the ADA as of now is still more conservative because of the large amount of data available with metformin. It is still considered the first line agent, and you move on to a second drug like SGLT inhibitor or GLP-1 analog in patients who have established cardiovascular disease if the HbA1c is more than 7. So that completes my discussion about empagliflozin and the endocrine perspective of the same. I would now hand over to my cardiologist colleague for taking the discussion forward. Thanks a lot.
Thank you very much, Dr. Bharat Sharma, for your views. Now I request Dr. Mahesh Fulwani to share his views from cardiology window. Mahesh, sir, please. Sir.
Okay, am I audible now? Hello?
Yes, sir, you are audible, sir.
That's great. Thank you.
Yes, sir, you can go ahead, sir. Thank you.
Thank you, Dr. Bharat. Nice elaboration about your diabetic perspective of SGLT2 inhibitors. You have made my job easy. You have given a lot of information about how SGLT2s are good and how does it decrease diabetes and how does this translates into decrease in their cardiovascular mortality. I would go slightly far more than that. Framingham heart study shows that heart failure is very high in patients with diabetes over 30 years, right? It is even more than coronary disease, total cardiovascular disease, intermittent claudication, or stroke. So in diabetic population, heart failure prevalence is very high. And over the years, we have seen that this did not decrease with the use of multiple drugs. Heart failure is most common outcome then myocardial infarction, stroke, and death in diabetic trials, maybe renal trial, IDNT, proactive altitude, or look ahead, or life, whatever trials. So heart failure was always more common than ACAs or MI or stroke and death also. So it's such an important entity, and we had no good drugs to control or prevent that heart failure. If you look at all the diabetic trials, this we are looking for last now almost 20 years, that Accord, Advance, UKPDS did decrease myocardial infarction when you treat the patient more intensively over years, not in short term. Short term trials with all the drugs did not decrease the macrovascular complications in diabetic, but longer follow-up, maybe 7 years, maybe 15 years, showed that it is decreasing the macrovascular complication, and microvascular, of course, did decrease immediately. But what happened to heart failure and hospitalization for heart failure did not decrease with good control of diabetes also in all the good large trials. What was the reason? We did not know till then. So meta-analysis of all 4 studies in patients with diabetes, heart failure for hospitalization for heart failure or fatal heart failure did not decrease with good control of diabetes also. And we all know that in order to decrease the cardiovascular death in diabetic population, not only glucose control, but blood pressure lowering, LDL cholesterol lowering, and diet and exercise and lifestyle have to be aggressive in order to decrease cardiovascular death. But even there also, doing all these things nicely did not decrease the hospitalization for heart failure or development of new hospitalization in all the major trials. So look at this. UKPDS, use of sulfonylurea, did not decrease heart failure. Insulin did not decrease. Thioglucagon increased risk of heart failure. GLP-1, of course, did decrease slightly. But Empagliflozin, as told by Dr. Sharma just now, Dr. Bharat, that it did decrease the development of new heart failure, recurrent heart failure, or hospitalization for heart failure. Now this was it. That with the use of placebo, there is increased chances of heart failure, but with empagliflozin, the heart failure is decreasing significantly. And this decrease, as Dr. Sharma has clearly showed, is starting right within 3 months or maybe even much more earlier than that. What is the reason? How SGLT2 inhibitors are affecting the heart failure? Of course, it is natriuresis, more of sodium loss along with glucose, because it is causing glucoseuria. The mechanism has been well elaborated by my friend. It is causing natriuresis. It is causing reduced preload, reduced afterload, and thus, because of these both decrease, there is decrease in the left ventricular wall stress. And as the LV wall stress is decreasing, the heart failure development, whether it is systolic or diastolic, both is decreasing. There is improved kidney function, and cardiorenal physiology is improving much more than expected. There is decrease in the interstitial edema, and as the interstitial edema in the lungs is decreasing, the oxygenation is improving, and once the oxygenation is improving, the whole circulatory system improves a lot, and therefore the development of heart failure is decreasing. How is the progress of evolution? We are moving from treatment of heart failure to prevention of heart failure. We all know that therapies which decrease or which are useful to treat patients with heart failure are ACE inhibitors or ARBs, beta blockers, and of course, small amount of exercise. This helps to prevent heart failure also. There are therapies that can be used only when the heart failure is established and we want to treat it, like ARNI, ivabradine, CRT or ICD, and MRS, right? And now there are many good medical management for patients who either have diabetes or they do not have diabetes, and we want to prevent heart failure. That means we want to prevent them from going from stage 1 of heart failure to stage 2 or stage 3 of heart failure. That means prevention of development of overt heart failure and development of symptomatic heart failure is statins, blood pressure control, and now we have SGLT2 inhibitors which will prevent development of heart failure in diabetic and in non-diabetic population also. So cardiovascular outcome trials in glucose leveling therapies, SGLT2 are the preferred choice in patients with or without established ASCVD and CKD. So this is a very important statement from the authorities. EMPA is indicated to reduce the risk of cardiovascular death in adults with type 2 diabetes and established CVD. So this is a good statement that when you want to use the mortality, you must think about using EMPA. Let's look about heart failure studies. So there are two studies, that is EMPA reduced and EMPA preserved. That is, what is that EMPA reduced and EMPA preserved? That in EMPA reduced, when the LV ejection fraction is to less than or equal to 40% at screening, and they have increased anti-proBNP level. That means they are having heart failure along with reduced ejection fraction, and the level of anti-proBNP is increasing as the LV function is also increasing. That means we are trying to enroll the patients who are more sicker, right? It is not that only LV function of 39 and with just minimal increased BNP levels we are increasing. But here, when the LV function is 36 to 40, the LV function has, anti-proBNP level has to be significantly elevated to prove that it is a significant heart failure. And this is along with good guideline directed medical therapy with the use of ACE or ARB, beta blocker, good diuretics, MRAs, ARNI, ivabradine, maybe device therapy or CRTs, etc. So this is Emperor reduced trial. In Emperor preserve, of course, as it is the name suggests, that LV function has to be more than 40%. They have to have structural heart disease or in the form of increased LA enlargement or LV hypertrophy, right? Documented by ECO, or hospitalization for heart failure within 12 months prior to screening, along with elevated anti-proBNP levels. So, right? So these are two good trials with EMPA ongoing. This is the design of trial. There is screening period, then there is randomization with EMPA 10 versus placebo and followed for 24 months or 20 months, depending on EMPA reg or EMPA preserved or EMPA. And there is, of course, period. So what is expected that EMPA reduced and EMPA preserved trials will determine the efficacy and safety of EMPA in HFrEF, effect of EMPA on symptoms, exercise capacity, and patient-reported outcomes in patients with HFrEF or HFpEF are being investigated with these two trials. And these trials are expected to deliver conclusive insights regarding the value of EMPA in the treatment of patients with heart failure. How this SGLT2 inhibitors are responsible for striking cardioprotective effect in patients with heart failure with reduced ejection fraction. See, it was thought that SGLT2 inhibitors will increase fasting levels of ketone bodies, which are hypothesized to enhance utilization of this efficient molecule as the metabolic fuel in failing heart. We all know that ketone bodies are very good for the failing heart, for the use of their for their efficient metabolic fuel. However, more important than that is SGLT2 inhibitors will slow the course of cardiomyocyte injury, and by inhibiting the sodium hydrogen exchanger, that is NHE1, in the myocardium, which is usually overactivated, and this inhibition will lead to increased intracellular calcium and sodium, which usually impairs the cardiomyocyte function. And this whole process, all anti-physiological process is taken care of. Also, it has been shown to inhibit, very importantly, activation of calcium calmodulin dependent kinase 2, which contributes to activation of NHE in the heart, right? And the action of EMPA to prevent this calcium overload will explain why the drug prevents time-dependent decline in systolic function over years, which is seen in experimental conditions. Are SGLT2 inhibitors in the future of heart failure treatment? Probably answer is yes, because the speculated mechanism is reduced cardiac preload, shift to ketone metabolism, as I said, adaptive cellular reprogramming, as I said, inhibition of NHV1, inhibition of sodium hydrogen exchange, improved endothelial function, and reduced cardiac fibrosis. So all these will prevent the development of heart failure, or if heart failure is already developed, it will prevent the progression of it so that patient's symptomatic status is well controlled. So let us see one of the trial, that is Emperor reduced trial, and it show what was it that Emperor reduced trial specified only 3 endpoints, right? And the endpoints is primary endpoint, that is composite of cardiovascular death and heart failure hospitalization. Secondary endpoint is first secondary endpoint was total, that is first and recurrent heart failure hospitalizations. And second secondary endpoint was slope of decline in GFR. This is very important. How is this drop in EGFR? What is the slope of that drop in EGFR? How it contributes to science and literature. The EMPA reduced trial showed that EMPA is superior to placebo in improving heart failure outcomes among patients with symptomatic heart failure, HFrEF patients on excellent baseline GDMD, irrespective of their diabetic status. What I want to say that let us see how it is helping us. What was the trial? The goal of the trial was to assess the safety. Of course, our primary aim is that patients should be safe, and efficacy of EMPA in patients with HFrEF and who were symptomatic, whether they had diabetes or whether they did not have diabetes, whether it is going to help both subset of population. Design was that it's one-to-one fashion. Were given either EMPA or placebo. Almost 3,700 odd patients were randomized, followed for 16 months, and mean age was 67, 24% were females. Inclusion was, this is standard inclusion, that patients more than 18 years, they had chronic heart failure with class of NYHA 2, 3, and 4. I'll say 75% were into class 2. LV systolic function has to be less than or equal to 40% because it was on such group of population. They had to have heart failure hospital within 12 months, and NT-proBNP levels had to be, as I said, if LV function is less than 30, 30 to 40, 30 to 35, or more than 35, the NT-proBNP levels keep on increasing. And if they had atrial fibrillation, this level would require to be double than if they did not have atrial fibrillation. All the patients who had ACS, stroke, or TIAs in the last 3 months were excluded. Those who had heart transplantation listed or LVAD were excluded. The reversible cardiomyopathy patients like peripartum or cardiomyopathy caused by chemotherapy were all excluded. Severe valvular heart disease patients were excluded because they will require surgery. ADHF was excluded. Implantable ICDs and CRTs in the last 3 months were excluded. This is very important. There, 75% populations were class 2 NYHA. Mean LV function was 27%, and 50% were diabetic, and 50% were non-diabetic. So this trial gives us an indication, that EMPA is useful not only in diabetic but in non-diabetic population also. Estimated EGFR was around 48, right? And all the patients were on good guideline-directed medical therapy like use of ACE or ARBs in almost 70%, ARNI in almost 19%, MRAs in 70%, beta blockers in 94%. This is very important. 12% patients were on CRT and 30% patients were ICD. That means despite good this, will EMPA decrease the primary and secondary endpoints? Let us see. What is the result? It showed that primary endpoint, that is composite of cardiovascular death or hospitalization for heart failure, it decreased by 25%. So this is very important, right? So hazard ratio was 0.75, that means 25% decrease in the risk of hospitalization for heart failure or cardiovascular death. First secondary endpoint, that is total of first and recurrent hospitalizations decreasing by 30%. And as I said, slope of decline in EGFR was significantly less. There is this drop of 50%. So this is a first trial which has shown that in non-diabetic patient, if you give SGLT2 in the form of EMPA, it is decreasing the decline in EGFR rate over time. So this is a very good trial to show that it is decreasing the renal outcome in patients. So this is how it is. As compared to placebo, EMPA is decreasing cardiovascular death or hospitalization for heart failure, and composite renal endpoint as compared to placebo, it is decreasing significantly more. So, EMPA-reduced trial has a major implication on clinical practice in the form that it will have a major impact on the management of patients with chronic HFrEF patients, whether or not they have diabetes. There is now compelling evidence that SGLT2 inhibitors should now be added to currently recommended treatments for this patient, this disease, that is HFrEF, whether they have diabetes or not. And how about safety? Let us see that. Safety, that is in the form of SAE, that is called serious adverse events related to cardiac disorders, was significantly less in the active arm, that is those who were on EMPA. Related to worsening of renal function was significantly less in the active arm. Volume depletion was almost same. Hypotension was same. Symptomatic hypotension was same. Hypoglycemia events were same. So ketoacidosis was not there. UTIs were same despite being on EMPA. Of course, as has been told by Dr. Bharat, that genital tract infection will be slightly higher in the population when they were on EMPA or any other SGLT2. So this was a good, safe drug to use in patients who have this kind of problem. So what it goes to conclude that EMPA is going to lower the risk of cardiovascular death or hospitalization in patients with heart failure. Among patients receiving recommended therapy for heart failure, that means either ACE or ARBs and beta blockers and ARNI and CRT and ICD and diuretics and MRA, those in the empagliflozin group had a lower risk of cardiovascular death or hospitalization for heart failure than those in the placebo group, regardless of presence or absence of diabetes. This statement keeps on coming again and again, because now, apart from DAPA-HF trial, we had no other good trial to show the use of SGLT2 in non-diabetic population is going to help them. Now we have a trial that it shows that it is going to help them. Secondary endpoints, let us see. Total hospitalization is reducing significantly. Composite renal endpoint is decreasing significantly. However, all-cause mortality, though slightly lower in the active arm, it is not reaching the statistical significance value. New onset type 2 diabetes is also same in the both group. Of course, change in HbA1c will be there with EMPA as compared to with placebo. Systolic blood pressure drop is same with both the arm, and hypoglycemic event is not significantly more with EMPA. So what it goes to interpret, that result of this trial shows that EMPA is superior to placebo in improving heart failure outcomes among patients with symptomatic HFrEF on excellent GDMT despite presence or absence of diabetes. Benefit is primarily driven by reduction in hospitalization for heart failure. Though, as I said, mortality reduction did not reach to statistical significance, there was also significant benefit in the renal outcomes. So this is a very important trial and mirrors findings similar from DAPA-HF trial for dapagliflozin. Even patients with severe LV systolic dysfunction, those who had LV function of less than 20% were also benefited. So snapshots, evolving research and insights, effect of EMPA versus placebo on body composition in patients with acute myocardial infarction. This is very good. So we are waiting for this to come out. Those patients who had acute MI and diabetes, how is the change of body composition? Effect of EMPA as on add-on therapy of transtubular potassium concentration gradient in patients with type 2 diabetes and ADHF. An effect of EMPA on arterial stiffness, endothelial function, and ventricular arterial coupling in type 2 diabetes, and followed for 1 year on EMPA. So let us see what are the trial results of these three trials will add to our knowledge much more in coming years. Thank you very much, and I hand over the forum to the host. Thank you very much.
Amazing talk, sir. Thank you very much for sharing your views. Now we have a couple of questions from the audience to both the experts. So with your permission, I'll take the question, sir.
Yeah.
So the first question is, now in heart failure, which SGLT2 inhibitor should be the first choice, whether it should be EMPA or DAPA?
See, if the person doesn't matter now whether he's diabetic or non-diabetic, of course, as Dr. Bharat has showed that it is the only drug which will decrease the mortality when the patient is diabetic, correct? If he's non-diabetic, we know that it is not going to matter much. So I would prefer use of EMPA as against any other SGLT2 inhibitors, because we have slightly higher evidence to decrease their mortality when we are using in patients of heart failure.
Okay, sir. Okay, sir. So second question is, suppose patient is on ARNI, then on beta blockers, then on SG, then on mineralocorticoid receptor antagonist. So if SGLT2 inhibitors are added, is there a risk of hypotension in the patient?
See, of course, there is some risk of development of hypertension, but if you see all the trials, as I have shown, the hypotension is same as placebo, number one. Symptomatic hypotension is same as placebo. So we should not be worried of adding SGLT2 inhibitors over diuretics, over ACE or ARB or ARNI, over beta blocker. So as long as patient is not symptomatic for his hypotension, that means his blood pressure is maybe 90, maybe 100, but he is symptomatic. He becomes dizzy on standing or he becomes fatigued. Then we should think about reducing the doses of diuretic first, because they are the drugs which are not going to decrease the mortality. They are only from symptomatic point of view. So we should reduce the dose of diuretic first and then think about reducing dose of other drugs.
Okay,
But
sir.
we should not be decreasing doses of EMPA or ARNI. Correct?
Okay, okay,
Yeah.
sir. Fine, sir. So third question is when to prefer SGLT2 inhibitors and GLP-1 analogs. So in comparison, so when SGLT2 inhibitors should be preferred and when GLP-1 analogs should be used in diabetic patients with cardiovascular disease.
The guidelines have given us a clear idea about which of the two drugs should be chosen. So if the patient has established atherosclerotic cardiovascular disease without predominant heart failure, then
Okay.
GLP-1 analogs would be the ideal choice. If the primary component of cardiovascular disease is heart failure, then SGLT2 inhibitors should be the ideal choice. Again, you have to look at other characteristics. If the patient has history of recurrent genital mycotic infections or urinary tract infections, or has a lower urinary tract structural issue, then in that case, GLP-1 analog would be a better option. On the other hand, a patient who has significant GI symptoms is not able to tolerate GLP-1 analogs, and the affordability could also be an issue for some patients because the GLP-1 analog therapy would amount to about 6 to 8,000 rupees a month. Although SGLT inhibitors are similarly costly, but still they would cost about 1,200 to 1,500 rupees a month. So the cost criteria also needs to be taken into consideration, the difference between an injectable and oral drug. So you have to individualize therapy based on the patient's clinical characteristics and the choice of the patient to some extent.
Okay, sir. Okay. So next question is, what should be the cutoff EGFR levels when SGLT2 inhibitors can be safely used?
See, so the most of the trials that have been done, the CVOTs, have included patients with creatinine clearance up to 30 ml per minute also. But
Okay.
when the creatinine clearance is between 30 to 40, 45 ml per minute, you should be extra cautious. You should probably monitor the creatinine more frequently because, as we know, when you start an SGLT2 inhibitor, there is a likelihood that the creatinine might actually rise in the first few months and the creatinine clearance might fall. Although in the long run, it helps in preserving renal function, helps in preventing development of CKD. But the initial stages, it is especially important that you are more careful when the creatinine clearance is below 45 ml per minute.
Okay, sir. So, so we have come to the end of the questions, sir. There are no more questions from the audience. So with this, we will be ending the session. So thank you very much for both the experts. So exceptional talks. The audience would have completely enjoyed the talk and at the same time enlightened on the information on the topic. So from Lupin, we are extremely grateful for accepting our invitation and being part of the event. So from my side, have a good night and a great week ahead, sir.
Thank you.
Thank you very much, sir. Thank you.
Thank you. Good night.